Dr. Liebman, thank you very much for such a kind introduction, and definitely it is my pleasure to talk today about the topic I actually love talking about. So today I'll review the cognitive impairment evaluation, or try to demystify how do we come from the chief complaint to the diagnosis. And there are several steps. We'll be actually talking about some clinical presentation about the complaints, about establishing the cognitive impairment profile, why is that important, and then what diagnostics we use in order to come to the diagnosis. So I do teach a lot of medical students and residents, and you always say that you have to start from the basics. And the basics, one of the probably most important information you can gather when you just sit down with a patient is actually evaluating their complaint, a chief complaint, and I'm going to get into that a little bit more. When you understand the chief complaint, when you understand what is the problem, then you start evaluating the disease. You know, did it happen? Did it start acutely? Did it start, or it's some slow, insidious process? And what is the progression, the speed of the progression? When we have that information, we make several more steps to determine the cognitive impairment profile. I will be talking a little bit about the selective vulnerability and why it is important, and that will guide us to further, to synthesize, use our neuroanatomical and neuropathological knowledge in order to come to the diagnosis. So let's start with a clinical presentation, evaluating the complaint. It is always very important to understand the chief complaint, because certain people mean different things, but sometimes they use the same words. For example, people present with a forgetfulness. Okay, we all assume it's memory, but for different people, it might mean different things. For example, for some, it could be true memory impairment. They tell the same story or they repeat questions, but for some people, it could be word finding deficit, which is more language problem. For some people, they might mean, when they say that they're forgetful, they're just getting lost, or they can't find objects in front of them, which is more type of neurovisual impairment. Or maybe people are forgetting how to use objects, which tells that they might be losing the ability having problems with their skilled movements. Now, why is that important? Because if it's truly the chief complaint is about the memory, then we're somewhere in the temporal lobes. If it is more the language problems, then we're somewhere, in majority of people, in the left parasylvian region. Or maybe if it is the neurovisual problem-based forgetfulness, then maybe we're somewhere more posterior brain region. Another complaint could be difficulty finding words. Again, frequently, it will mean actually true aphasic problems, but sometimes people might mean that they're losing the meaning of the objects, okay? And that is more semantic processing problem. Some people might, when they say they have difficulty finding words, they're stuttering. Or some people have difficulty finding words, in reality, they actually have memory impairment. And I wanted to say that at the beginning, some of my slides will have a lot of information. I actually, listeners wants to concentrate on what I'm saying, and I'm just gonna point to the most important information and use a slide as just a reference. So now when we clearly understand the chief complaint or the problem, underlying problem, then it's important to know how did it start. Acutely, or it's a slow, insidious process, because we automatically will think about different things. You know, the acute onset, could it be the stroke, the clouded dementia, or certain central nervous system infections? Or the slow process, neurodegenerative disease, nutritional deficiencies, some chronic infections, and other conditions. Tempo of the progression is very important, because it completely puts us into a different territory. If it is a rapid progression, somebody started developing cognitive problems and rapidly progressed. Are we dealing here with a prion disease, infectious diseases, autoimmune disorders, or it is a slowly progressive disorder such as neurodegenerative disease or certain cancers? So when we have this good understanding of the clinical complaint and the progression, then we move on to the establishing actually what is the problem, evaluating the cognitive profile and evaluating the actual impairment. Now, why is that important? And what does that develop? How do we do that? We do that or either in the office or proceeding with the neuropsychological testing. It tells us what domains are affected and which domain is affected the most. That domain is usually the one that was affected first. And why is that important? Because certain diseases affect certain brain networks initially. And that is what is called selective vulnerability. That is, the certain network, like memory network, language network, or neurovisual network, is more susceptible to certain disease process. Just to demonstrate this, or the selective vulnerability. For example, the tauopathy that is seen in Alzheimer's disease, preferentially initially in majority of people affects the medial temporal lobe structures, as opposed to a little bit different tauopathy of frontotemporal lobe or degeneration type. It preferentially affects the frontally based cognitive networks or the salience network. And again, because of this selective vulnerability, the clinical presentation obviously will be different. I will pause here about we're talking about the evaluation and just review the cognitive neuroanatomy and what do we mean when we say that, or the biomarkers, just to make sure that listeners understand. So when we talk about the memory, there's like the classification, or there are several classifications, but this is probably the most frequently used classification. And we're usually, when we're evaluating patients for forgetfulness in the clinic, we're thinking about declarative memory. That is episodic memory, our ability to remember the actual episodes, what was happening, as opposed to a semantic memory, which we're evaluating, which is responsible for storing the semantic information. And anatomically, the temporal lobes are the ones that are heavily involved in the memory formation, whether it's episodic or semantic. And the more medial temporal regions are important in episodic memory formation, as opposed to anterior, lateral, and inferior regions of the temporal lobe for the semantic memory. Now, not going into this slide, this is just a demonstration of the medial temporal lobe, the part of the brain that is responsible for optimal functioning of the episodic memory. And there are other structures, anatomical structures that are involved in this function, such as mammillary bodies, certain nuclei of the thalami, and others. Now, the memory itself is not just this. It's memory. There are several steps, for us to form the memory. And the first step is probably is encoding. Then, we have to have the ability to retain the information, and our brain has to have the ability to retrieve the information. That is, find the correct information at the necessary time. Now, a little bit different anatomical structures are involved in these steps. The retention itself is, as I said, heavily dependent on the medial temporal lobe structures and that PAPE circuit, as we know. But the encoding and retrieval becomes dependent on the executive networks. So if we have amnestic profile that has just retention problem, we're anatomically somewhere in the medial temporal lobes or the PAPE circuit, as opposed to if the problem is encoding retrieval, then obviously we're involving the more widely distributed executive networks. Language. Anatomically, we know that in the all right-handers, the language is in the left hemisphere. In the majority of left-handers, it's still in the left hemisphere. That classically, anatomically, it's located around in the left pericilian region. But now with all the additional studies that are available to research brain functions, such as functional MRI, we do understand that language is more diffusely located. For example, the actual word meaning or object meaning is more located in the anterior temporal poles. But again, when we have a language problem, we're looking somewhere in the majority of people in the left pericilian region. Neurovisual function, it's our ability to, to visually process information, to visually put us in our body in certain, in the environment. And that is more heavily dependent on the more posterior head regions. The occipital lobes are important in initial visual processing, but then the temporal lobes come in the semantic processing, meaning recognizing the objects, and while the parietal lobes are important in placing those objects in the environment and guiding our motor movements through those objects. When I will say executive function, the executive networks are a little bit wider distributed, but the one we usually test and the one we evaluate is that the central executive network function that is heavily reliant on the prefrontal cortex and the connections with the higher processing areas of the parietal and temporal region. And one more, the praxis, our skilled movements, and that's anatomically heavily reliant on the left parietal lobe and bilateral prefrontal cortex. So understanding this neuroanatomy, because this translates into the clinical presentation, then knowing the selective vulnerability will help us to actually start putting together the diagnosis. Now, again, just for everyone to understand, when I say biomarkers and structural, functional, disease-specific biomarkers, what are we talking about? Structural biomarkers, it's your CAT scans and MRIs. Okay, helps to establish the regions that are affected, whether there is some, the mass lesion or whether there is some atrophy pattern, like you see here in the image on the right. Clearly, there is a generalized atrophy, but also atrophy that is fairly significantly affecting those medial temporal lobe structures. And this, 90% chance probably Alzheimer's, 10% chance other rarer conditions. Functional biomarkers, so that's your PET scans and SPECT scans. And so that's your evaluation of the metabolism, and you have to understand that in the brain, the metabolism depends on the how much the glucose is needed in that area. So if there is atrophy or there is loss of synapses, there is less glucose needed in that brain, and we see that there is a decreased metabolism. So just by giving more glucose, you cannot affect the process. But anyway, certain patterns of the loss of the glucose utilization or the blood flow in those areas are associated with again that selective vulnerability because of the networks that are affected, and certain diseases can present with that. And disease-specific biomarkers, so that would be your amyloid PET scan for Alzheimer's disease or CSF analysis for amyloid or tau. And again, when it comes to disease-specific biomarkers, we're more talking about Alzheimer's disease clinically. On the research side, there are disease-specific biomarkers for other neurodegenerative diseases as well. So again, going back, so that was just a quick review of neuroanatomy and what do we mean when we say biomarkers. Going back to the diagnostic process, we have a clinical presentation, we establish neurocognitive profile, we know the principle of selective vulnerability, what pathology likes, what networks, and that's when we start our diagnostic process. Let's start with the most common impairment profile, and that is amnestic profile. Again, I was talking about, the memory formation the memory formation happens through several steps. Retention, our brain's ability to retain information, is heavily dependent on those medial parts of the temporal lobe plus some other structures. So when we establish that profile, like actually the amnestic profile is due to the retention, what do we think? What can be causing this? Again, if it is slowly progressing, the most frequent will be Alzheimer's disease because that's where the abnormal tau develops. Now, that's where we need to, the structural and functional biomarkers will not help us to be 100% sure about the diagnosis, and that's where we need the disease-specific biomarker studies, such as amyloid PET or cerebrospinal fluid analysis, because that will help us establish a diagnosis. And the reason for that there are some rarer conditions, not going into details, but some rarer conditions that can clinically present, and actually on initial evaluation, such as structural biomarker studies on the MRI, might look very similar like Alzheimer's disease. For example, late onset hippocampal sclerosis or temporal tauopathy without amyloidosis. Other neurodegenerative diseases also affect the episodic memory network, but it's usually later in disease process. Now, I was saying that the tempo, understanding the tempo of the disease is very important. And the reason for that, if we have amnestic profile like presented with acute onset, okay, or very rapidly progressing, certain strokes can present like that. And even actually isolated hippocampal strokes like posterior cerebral artery stroke or the encephalic vascular insults can have that pure amnestic profile. Certain metabolic deficiencies, like a thiamine deficiency, the classical presentation is your amnestic profile. It's really not the medial temporal lobe problem, it's that extended network problem where you have thalamic problems and mammillary body problems. But again, clinically that will look when you test them, they look the same. Traumatic brain injury, not surprising. If there is a sharing effect, and especially going through the parahippocampal regions, it can affect the memory retention. Hypoxic ischemic brain injury. Also, the hippocampal cells, those medial temporal lobe structure cells, are probably one of the most sensitive cells to the lack of oxygen. And if there is even the disruption of the blood flow up to 5 minutes can leave people fairly amnestic. There are other conditions that can also prefer that, or at least initially prefer that network. Certain infections, classically herpes simplex encephalitis, or inflammatory conditions such as autoimmune or paraneoplastic encephalitis, limbic encephalitis can also present with this amnestic profile. But again, we can really intelligently come to the diagnosis only if we understand what is the cognitive profile, what is the tempo of the disease. If the symptoms are transient, just lasted 24 hours or so, transient global amnesia, again, likes the same network. Or could it be an amnestic syndrome related to the medial temporal lobe epilepsy? These people can present with a fluctuating, long-lasting, fluctuating deficits in their memory formation. Now, what about if we have a problem with the encoding or a retrieval? Again, medial temporal lobe problem is a possibility, but if we have more pronounced encoding and retrieval problem, then we're probably dealing more with the executive network problem. And executive networks are widely distributed through the brain. These are networks that connect your prefrontal cortices with the higher processing areas of the parietal and temporal regions. From degenerative disease standpoint, Alzheimer's disease or non-Alzheimer's disease neurodegenerative conditions such as Lewy body disorder or frontotemporal dementia. Traumatic brain injury, not surprising, because as I said, executive networks are very widely distributed, so they're very sensitive to the injury as well. Hydrocephalus can present also with the amnestic syndrome, but more so dependent on the executive network problem. And that is, again, not surprising, because when you start putting the pressure on the brain, it decreases the metabolism, it decreases the blood flow. Those networks will be affected as well. Demyelinating disorders can obviously, again, these are widely distributed networks, and they're definitely very easily susceptible to the demyelinating disorders such as multiple sclerosis. Or vascular cognitive impairment. Again, for the same reason, because of the wide distribution, there is a higher chance of developing developing the problem because vascular structure is affected. So again, you see, just understanding really the cognitive profile and at what stage it broadens or narrows the differential diagnosis, and then you can go, and sometimes you just do take the structural biomarkers and you have a diagnosis. Sometimes you need to make those extra steps with, going through the functional biomarkers or more disease-specific biomarkers or even something more specific. Language impairment profile. Again, as I said, it's in majority of people, the problem will be located mostly in the left perisylvian region. Now, with the language problems, that's where it's really very important to understand the onset and the tempo of the disease. So if it is fairly acute onset or fairly rapid progression, we're talking about the focal lesions due to the stroke, tumor infection, for example, your typical Broca's aphasias or Wernicke's aphasia or transcortical motor or sensory aphasias. But if it is a slowly progressive language impairment, then we have a neurodegenerative processes, such as if it is primarily just affecting the language network, at least initially for the first year or 2 years, primary progressive aphasia syndrome. It could be fluent or disfluent types. And again, there is a certain subtype, for example, logopenic primary progressive aphasia that is more that is associated with underlying Alzheimer's disease, as opposed to other types that are more associated with frontotemporal lobe or degeneration. Or it could be the part of other degenerative diseases, such as frontotemporal dementia corticobasal syndrome. Now, the next several slides will just demonstrate the certain findings, for example, and I will not show the stroke lesions, but more of the progressive conditions as is seen in the primary progressive aphasia. Here in the MRI, just a plain MRI, you see clearly that there is atrophy, but if you compare the temporal lobes, you see that the left temporal lobe is definitely more affected than the right temporal lobe, and this would be the typical finding with the primary progressive aphasia. Again, here you see generalized atrophy, but if you compare left and right temporal lobes, it's clear that there is a difference. You see the left temporal lobe is more affected. Another, also very similar, the left perisylvian region. There is an asymmetric atrophy of that part of the brain, and that would be typically seen for primary progressive aphasia. Now, this is the functional scan, and you can see that there is a diminished need for the glucose in the left perisylvian region. You see those arrows there, and that translates clinically into the language impairment. So here, these are all the studies that help us to really understand the diagnosis better. If you have primary progressive aphasia of more logopenic type, then you would proceed with the Alzheimer's biomarkers. Neurovisual impairment profile. Again, the preferential pathology that likes those areas. If we're talking about slowly progressive diseases, your Alzheimer's disease, your synucleinopathies such as the Lewy body dementia or Parkinson's disease dementia. And this is just a very dramatic example of the posterior cortical atrophy syndrome, which is a posterior variant of Alzheimer's disease. And you see really how the occipital parietal areas are affected by the disease. And in the lower images, you see the decreased metabolism in the posterior head regions that are responsible for the visual function. Again, just to show that sometimes how helpful could be the functional biomarkers on your right side, the dementia Lewy body typically have more posterior affects more posterior head regions, and that's why these people have more neurovisual problems as opposed to the Alzheimer's disease, where occipital metabolism at least is preserved. This is just to show that the hot colors are the ones that shows the areas that are affected, and you can see that the occipital parietal regions in the Lewy body, as opposed to more higher processing areas in Alzheimer's disease. This executive impairment profile, again, what pathology likes those executive networks, if it is the network that is affected initially. We're looking into different than pathology of frontotemporal lobar degeneration, Alzheimer's disease, vascular disorder, or hydrocephalus. Just to show some examples of the frontotemporal dementia, you see that there is also generalized atrophy, but as frequently typical of the disease, they're a little bit asymmetrical, and it's on the right side. There is more atrophy on the right hemisphere, predominantly the right frontal lobe. Again, here you see more generalized atrophy, but if you compare the frontal lobes and you see that the temporal lobes, you see the more predominant right than left, but both temporal lobes are more affected than the rest of the brain. And here again, also just another example of the frontal lobes being affected more in the frontotemporal lobe. And you can even see that you don't need even further studies. You can see that in just doing the structural imaging. This is the PET scan showing this pronounced hypometabolism in bilateral frontal regions, but the right side is definitely affected more than left. And this is just side-to-side comparison, how differently it looks, frontotemporal dementia, for example, from Alzheimer's disease, where Alzheimer's disease have more posteriorly pronounced hypometabolism, at least initially, as opposed to frontotemporal, have more anteriorly, and obviously, as the name implies, in the frontal and temporal lobes. Vascular cognitive impairment, as I said, one of those conditions that likes executive networks, just because the executive networks are so widely distributed. And as I mentioned, the hydrocephalus also frequently affects the function of those networks. Again, so just to summarize, that's how we came here. We start with a complaint, but the complaint is something that actually puts you on the right pathway. When you understand the really complaint, the problem, then you get into the cognitive impairment profile, then you'll be able to choose the appropriate diagnostics, which will lead you to the correct diagnosis. And that will be all. Thank you. So we have some questions. And one question is, can you comment on FDA approval of aducanumab? And the way I say, it's whatever side you choose, you might be wrong with this approval. So because the controversy is that there were two studies. One study showed that both studies showed that it helps clear the amyloid from the brain. But one study showed that it slows down might slow down the clinical progression. Another study showed that it did not. Now, the FDA looked through the data, and because this is the first disease-modifying therapy, they approved this treatment with a condition that the company will be gathering more information. So as when it comes to the offerings to the patient, I think the patients should be aware that there is a treatment, should have this option when they fully understand what that entails.
We have another question is, what is your perspective of the cerebellar role in cognitive dysmetria, particularly in context of executive cognitive functions related to multiple psychiatric disorders, schizophrenia, ADHD, bipolar, etc.?
It's a very good question because there is there is I think we have enough data to say that cerebellum does have a role in a cognition because of all these wide connections with the frontal networks, with the executive networks, and we do know that sometimes people present with the cerebellar lesions or cerebellar problems, and they have cognitive problems. The memory problems, the dysexecutive syndrome, or even sometimes people present with the aphasic syndrome while they have just the cerebellar problems. So we have enough. We have enough data to really say that cerebellum plays a role in that, but we definitely are not there we don't completely understand how is that interconnects with the rest of the brain.
We have time for one more question, although there are so many. I'll try to decipher or distinguish between. We know that we have a really rather robust, comprehensive normal pressure hydrocephalus clinic. And older patients, obviously, with atrophy and ex vacuo have enlarged ventricles. How do you distinguish with cognitive problems, and it's an ex vacuo problem, versus true hydrocephalus with MPH?
Yeah, very good question, because sometimes it's clear and sometimes it's not. When it's clear, we don't necessarily have to talk about it, but those cases when it's not totally clear, you have to, you have to, again, that's where the understanding the actual cognitive impairment profile helps, because if somebody presents with a progressive aphasia and they have, well, then hydrocephalus probably had nothing to do with that. But if they have psychomotor slowing, dysexecutive problems, and memory problems based on the executive network problems, it could be it definitely can be a possibility that is causing problem. Now, normal pressure hydrocephalus is rarely just a cognitive problem. You do have to, frequently majority of people have movement problems, many people have autonomic problems as well. But that's where the coming to the center is helpful, because you have this comprehensive team that evaluates, your cognition, your movements with a physical therapy. You proceed with a large volume LPs, and the neuropsychologist, neurosurgeon is available on site.
That was fantastic, Dr. Gliebus. There's so much to think about after that talk. Thank you again.
Yeah. Thank you.